Baragwanath Hospital. Officially opened on 23 September 1942, the now Chris Hani Baragwanath Hospital is the largest in Africa and third largest in the world. Originally named the Imperial Military Hospital Baragwanath, it was built for the British and Commonwealth soldiers returning from the Middle East in the beginning of the Second World War. Located next to Orlando, its construction began in 1940 from a plan of 2 hospitals. Named after John Albert Baragwanath, who had owned a nearby hotel that served as a rest stop for travelers heading to Kimberley during the gold rush. It was staffed primarily by British, South African, and Allied military medical personnel. Had approximately 1,544 beds and served wounded soldiers from many different nations. The hospital operated as a self-contained medical city, with wards, operating theaters, labs, and even its own power plant and water supply. During this period, Black South Africans were largely excluded from care, unless they were enlisted military personnel or involved in support roles. With the end of World War II in 1945, the British military vacated the facility. The Union of South Africa's government assumed control of the facility and transferred it to the Transvaal Provincial Administration, TPA. This move marked the beginning of a profound transformation not just in the function of the hospital, but in its symbolic role in South African society. In 1946, the hospital was officially renamed the Non-European Hospital, Baragwanath, a title that starkly reflected the racial categorizations entrenched in South African law and life. Johannesburg's black population had swelled dramatically due to rapid urban migration driven by industrialization. Yet healthcare services for black people were virtually non-existent in urban centers, and when available, they were deeply underfunded, segregated, and inferior. Baragwanath filled a massive vacuum. A shift in mission, but not in equality. Though no longer under military command, the hospital retained much of its infrastructure, including equipment and layout, but its entire patient demographic shifted. Now, it was to serve black workers in the mines and factories of Johannesburg, residents of the emerging townships like Orlando and Pinville, and the poor, sick, and injured from across the Transvaal and beyond. But while the doors were open, the environment was far from equal. Black patients were treated in segregated wards, often in overcrowded conditions. The facilities and resources were a fraction of what white hospitals received. Medical staff were predominantly white, and black nurses or orderlies faced limited training, advancement, or recognition due to systemic racism. The name Non-European Hospital itself institutionalized the notion that the hospital existed outside of the mainstream system, a stopgap, rather than an equal institution. Despite its limitations, Baragwanath began to embed itself in the daily lives of the black communities surrounding it. It was one of the only places black South Africans could receive serious or emergency medical care, from childbirth and tuberculosis treatment to surgeries and accident trauma. For many, Bara became synonymous with survival. The hospital's presence also started attracting black medical professionals and students, though in small numbers, and often under restrictive policies. The seeds of black medical excellence were sown during this period. While the hospital opened to black patients, the broader framework of white supremacy remained intact. In fact, this period coincided with the tightening grip of segregationist policies. Demand at Baragwanath surged rapidly. Johannesburg's black population was exploding, fueled by post-war industrial growth and the steady pull of migrant labor. But while white hospitals remained well-funded and lightly burdened, Baragwanath had become the sole beacon of medical hope for black residents. As a result, the hospital experienced severe overcrowding. Wards meant for 20 people held 40. Patients waited hours, sometimes days, for treatment. Makeshift beds and stretchers filled hallways and courtyards. Yet, under these strained conditions, Baragwanath grew not only in size, but in specialization. It began developing full-fledged departments in general medicine, surgery, pediatrics, obstetrics and gynecology. Infectious diseases, such as tuberculosis, which ravaged Black communities with little government intervention. It was an impressive evolution made even more remarkable by the environment in which it occurred. Baragwanath's expansion could not hide the institutional racism embedded in its staffing and training models. The majority of doctors and senior staff remained white, often appointed through state-controlled channels. Black nurses, orderlies, and assistants were routinely denied access to advanced medical training or forced into inferior, segregated courses. They were paid less than their white counterparts and barred from positions of leadership or professional authority, regardless of competence or experience. Medical hierarchies reinforced the apartheid structure, ensuring Black health workers were essential but never empowered. Yet despite the constraints, many Black nurses and trainees served with extraordinary skill and compassion, becoming unsung pillars of the hospital. In 1947, the Johannesburg City Council, under pressure from the national government, established Moroka Emergency Camp. It was designed to temporarily house the rapidly growing population of homeless Black residents, many of whom had been evicted from inner-city neighborhoods or migrated from rural areas. Similar camps were set up in Orlando, Pinville, and central western Jabavu, which alone was housing an estimated 89,000 people. These camps were makeshift and desperately under-resourced. Moroka, in particular, earned the grim title of Johannesburg's worst slum area. The township became notorious for its overcrowded conditions and the severe lack of basic services. People crammed into basic shacks and shelters, and there were no proper roads, sewerage, electricity, or running water. It was an environment marked by poverty, illness, and desperation. Baragwanath Hospital, already struggling with limited resources, had to contend with an overwhelming influx of patients from these impoverished areas. The hospital's wards were crowded, its staff overburdened, and its facilities stretched beyond capacity. The lack of trained Black medical staff, coupled with an underfunded healthcare system, meant that many patients received only basic care, despite the rising number of serious medical conditions. This intense pressure placed on the hospital, exacerbated by the squalid conditions of the surrounding areas, created a toxic cycle of disease, neglect, and death that the hospital was ill-equipped to address. Sadly, on 26 May 1948, South Africa saw a seismic shift in its political landscape. The National Party, led by the fiercely determined Daniel F. Malan, riding on a platform of Afrikaner nationalism and racial segregation, triumphed in the general elections, toppling the United Party and ending the era of Prime Minister Jan Smuts. With this victory, the country was thrust into a new chapter, one that would prove to be the darkest in its history. The National Party's ascension immediately marked the beginning of apartheid, a brutal and oppressive regime that would cast a shadow over South Africa for decades to come. Segregation was entrenched in every layer of society, from education and housing to transport and health. Funding models increasingly favored white institutions. Hospitals like Baragwanath, built as a reluctant response to black health needs, were now caught in a tightening noose. Funding policies were weaponized to reward white-only institutions. White hospitals received state-of-the-art equipment, better sanitation, and continuous upgrades. Their staff were drawn from a growing pool of well-trained white professionals, products of elite medical schools that black students could not enter. Meanwhile, Baragwanath and other non-European hospitals were systematically underfunded. Budgets were slashed or frozen despite rising patient loads. Infrastructure decayed while expansions were delayed or denied. Medical supplies were rationed, and life-saving equipment arrived late if at all. By the early 1950s, Baragwanath was serving over 100,000 black patients annually. Yet the hospital was operating with fewer resources than white facilities, treating a fraction of that number. Doctors, nurses, and staff, black and white alike, struggled heroically to meet the demand. But the apartheid state had made its stance clear. Black lives could be treated, but not invested in. This was not just medical neglect. It was policy-driven suffering, embedded in the machinery of government, and justified through the rhetoric of racial superiority. And unfortunately, things would go from bad to worse when the Group Areas Act of 1950 was passed. Suddenly, the hospital, already overwhelmed, found itself serving even more people, now coming from even farther, often traveling for hours just to reach the gates. It was the beginning of a cruel paradox. More patients, fewer resources. More suffering, less support. Apartheid's architects didn't just separate races, they separated access, mobility, and hope. And in the center of it all stood Baragwanath.